All right. All right, going to give a few seconds to let more people join us today for this Friday's webinar. I'm excited about this one because we've been working on this for a few years now, our minority rural coronavirus insight study, as we call it, MRCIS. And the team that has been leading this longitudinal study is going to explain what's been going on and how it's been working over the last 3 years, from anywhere from inception to where we're going and going into the future. Real quick, just for everybody, to make sure everybody knows, if you have any questions, please put them in the Q&A box and we will get to them. And then if you have any comments on the side you'd like to share, please go ahead and share them in the comment section. And both of those icons are below the screen. This webinar will be led by NMQS very own Dr. Makella Coudray. She told me how to say it right 3 seconds ago, and I messed it up again, but I'll let her do it, her voice and accent. She's originally from TNT, and she's an epidemiologist working here at NMQF. And so I will let the smarter folks go ahead and lead today's discussion, and please join us in participating. One last announcement too, and I'll put a link in there. We have our 40 under 40 nominations that are coming out, that are out right now and be announced later this year. So if you know someone, please direct them to apply. Dr. Latrice Landry, one of the panelists on this day's call, is a 2017 honoree. So without further ado, I'll turn it over to you, Doc.
Thank you, Brandon, and thank you for the introduction. You got the most important part right, that I'm from TNT, so it's okay about the name. Today, thank you for joining us. I would like to talk about our study, the Minority Rural Coronavirus Insight Study, or what we call MRCIS, and we'll be taking an in-depth look at what racial and ethnic disparities are associated with SARS-CoV-2 infection among medically underserved populations. And I will be your moderator for today, and my name is Makella Coudray. On our esteemed list of panelists, we have Ms. Shantoy Hansel, who's a research associate at NMQF with extensive background in laboratory sciences and public health. We're also joined by Ms. Christina Edwards, who's the director of clinical trials at NMQF and has years of experience conducting multi-site clinical trials, including those from NIH. We're also joined by Dr. Latrice Landry, who's an instructor at the University of Pennsylvania. She's a genomicist who has additional training in epidemiology. We're also joined by Dr. Ola Akinboboye, who's the medical director of the Queen's Heart Institute, cardiologist by training with additional background in public health and health administration. We're also, last but not least, joined by Dr. Maya of Quest, who's a medical and technical consultant for the entire organization, but he also has special emphasis on clinical pathology for the eastern region of Quest. So firstly, what is MRCIS and what are we trying to accomplish? MRCIS is a 5-year prospective multi-center cohort study. A lot of words, but basically we are just recruiting participants at baseline and following them into the future for 5 years. Enrollment began in November of 2020 and ended April 2021, and the study will be ongoing till approximately the spring of 2026. But one unique aspect of our cohort that we wanted to highlight is that recruitment actually began before the SARS-CoV-2 vaccine became available. So we began in November of 2020, and the first vaccine became available in December of 2020. But of even more interest is that one of our clinical research sites based in Louisiana was able to complete all of their recruitment before the vaccine became available in that state. So we do have a portion of our cohort who's completely vaccine naive. To be included in the study, we were looking for adults, so age 18 years and older at the time of enrollment, who were able to consent to participate and complete all of the study procedures and who presented at federally qualified health centers with which we partnered for services. At the baseline visit, they completed an informed consent form, just agreeing to the study procedures, a baseline survey that explored various components of health, including sociodemographic determinants of health, access to resources, prior medical history, and at the time, if they presented with any COVID symptoms. They also participated in sample collection, which was to be used for future testing. At this time, the MRCIS cohort comprises of approximately 3,500 participants who were enrolled at baseline. And of those, we have definitive SARS-CoV-2 test results. for 3,200 approximately participants. The difference came in with that some of the samples that we collected returned inconclusive results. But of the approximately 3,200, we have definitive results of either positive or negative for SARS-CoV-2 infection. Just looking at the racial ethnic profile of the population, we have the majority of participants, approximately 51% that identified as Hispanic or Latino. We had 26% that identified as Black non-Hispanic and 21% that identified as white non-Hispanic. So we see we have a high proportion of people who are minority populations. And with that, it brings me to my first question that I would like to direct to Dr. Ola. Can you please comment on why was there specific focus on medically underserved populations? You're on mute, Dr. Ola.
Yes, I just unmuted myself there. Thanks, Dr. Coudray. Well, we focused on medically underserved populations because available data suggests that rates of infection, morbidity, and mortality from COVID in underserved populations, including Black or African Americans, American Indians, Latinos, and Asians, are significantly higher than in Caucasians. However, most of this data came primarily from cross-sectional studies. What we are doing is to examine the impact of COVID-19, particularly in underserved populations, in a longitudinal fashion. We are also looking at the impact of social determinants of health on morbidity and mortality from COVID-19. And another dimension to the MRCIS study is that we are examining the impact of COVID-19 in rural versus urban dwellers. This is an area where there is very limited data.
Thank you for that, Dr. Ola. And just picking back off of that, the main objectives of MRCIS were to determine the racial and ethnic minority groups that are most susceptible to SARS-CoV-2 infection, as well as to determine which groups experience the most severe cases or are most likely to die from a SARS-CoV-2 infection. And to this end, one of the key components of MRCIS was that the samples were collected for future testing in areas of viral presence testing, antibody testing, as well as additional tests looking at the health profile of these participants, examining CBC, hemoglobin H1C, glucose, and vitamin D. We also have a component of biobanking and genomics, where additional samples were collected for future genomic testing. Now, this question I would like to pose primarily to the entire panel for feedback. Anyone can answer. But what were the key hypotheses for MRCIS? Unmute, Dr. Ola.
Yes, I'll take that question on. Now, there are three what I would call overarching hypotheses for MRCIS. I mean, there are some other sub-hypotheses, but I'm not going to go into that. The first one is that racial and ethnic minority groups are more susceptible to becoming infected, develop severe disease, and die compared to whites. That's number one. Number two is that social and structural determinants of health contribute to COVID-19 susceptibility in racial and ethnic minorities. And the third one is that there are underlying genetic and biological causes driving differential disease outcomes associated with COVID-19 in racial and ethnic minorities.
Thank you. If no one else from the panel would like to comment, I can go ahead. To this end, and just piggybacking off of one of the comments that Dr. Ola made about specifically looking at rural versus urban populations, we partnered with federally qualified health centers across 5 states who served primarily medically underserved populations, and 4 of these FQHCs had a rural designation, meaning that they served rural populations in the area. And this is primarily where participants were recruited from for the study. And given that we had such a focus on these populations, the recruitment strategy and recruitment efforts were very instrumental to amassing the cohort that we were able to include. So Dr. Latrice Landry, could you comment on the process of selecting these research sites and recruiting participants?
Absolutely. I think it's important to remember that this was an emergency, and we were seeing that minority populations were not getting the services or access that a lot of other populations were getting. It wasn't clear what was happening or why the rates might have been higher in these communities. And so the process for recruiting patients and selecting sites might have been different if it hadn't had that sort of urgency to it. We leveraged partnerships and relationships to with existing federally qualified community health centers and community partners and corporate partners to help us sort of get access and build infrastructure in the communities. The idea was to take the research to where minority populations are, not necessarily have people have to go to major academic centers for research, but take the research to the community. And so we leveraged those partnerships that we had in those existing relationships and did the process of recruiting participants through a volunteer sample where participants were able to be recruited, able to get COVID testing and get their results back. I think that the way the process came together was pretty impressive and happened in a quick fashion, which I think is something that might be a model for how others can leverage resources to vulnerable communities in times of need.
Thank you, Dr. Landry.
I'd just like to add that one of the concepts that was novel at the time was to take the research to where the patients were, the participants. Again, being involved in clinical research, many folks on this call probably, and in our panelists, will always sit back and say, bring the participants to the academic center because that's where the brain power is. In this case, we take the opposite. We want to take the research to the communities that are served by FQHCs, and that's one of the very unique features here.
Thank you for that. And if you permit me, I just wanted to follow up with an additional question. Just based on the recruitment strategy that you implemented and the success that you saw, are there any changes that you would make if you were to just repeat the study in the present day climate? Would you implement the same strategy, or the changes that you would consider making?
I think that's an interesting question. One of the major challenges is implementing research in institutions and communities where there is no research infrastructure. And I think that was one of the major challenges. However, I'm conflicted by saying, oh, I would do the study again from a outcomes perspective, that I would, sort of flip the script and do implement the study where there's more infrastructure, because I think that's part of the problem. The communities are often left out. The infrastructure for research can sometimes be costly. It can be personnel. And some of those times, it gives access to a broad variety of research, clinical trials and other things. What we did here with a lot of effort and sort of collaboration with the directors and the staff of the community health, federally qualified community health centers, was to try to build research infrastructure. It is also one of the challenges, but I don't think I would change it. I think what I would do is continue to invest in building infrastructure at those sites and more community sites. If another emergency or pandemic were to happen, the existing infrastructure allows us to implement the things that were implemented across the country and sort of major cities and academic centers more effectively in vulnerable and rural communities.
I will follow that up by also adding that if there is something I would like to do differently, would be to perhaps maybe wrap this up a little bit slower and spend some more time in training the FQHCs, because some of them were actually research naive. And again, I love my hat to all the science, the They took on the challenge, they quickly got themselves organized, and they made it happen. But if I was doing this all over again, there probably be a little bit more time dedicated to training and getting the sites ready for these trials.
And just on a somewhat humorous comment, when I was first introduced to the concept of maybe this project happening, and based on my prior clinical research experience, I said, oh, well, we need about 6 months to get the protocol written, the sites trained, identified, etc. And they said, well, we got 6 days. So in a certain sense, the speed at which this was done, I consider it professionally miraculous in terms of the recruitment and cooperation, etc. So it was done very rapidly because there was an emergency and we wanted to get this out quickly. So it's thanks to the sites and the team here and the participants for enrolling so quickly.
And I think that's a testament to a lot of the work that we get done at NNQF, that we push forward and we're able to execute efficiently. And with that, it's a perfect segue to the question for you, Ms. Christina Edwards. What challenges, if any, did you face executing the study, and what did you learn from it?
So, you know, as Dr. Meyer, Dr. Landry, Dr. Ola all stated, it did come together rather quickly in the midst, November 2020, in the height of the pandemic. So we did experience our fair share of struggles with getting everyone started up. Again, some sites were more experienced than others in the research field, so that came, with its different challenges. And just mobilizing the study and everyone's challenges were different. Every site did not face the same issues. What worked at one site didn't work for others. As mentioned, we have a site in Olympia Fields, Illinois. They experienced some recruitment goals. They have over 20 health centers, and they initially decided to go in a more rural area for their first to begin enrolling. And then they realized they weren't meeting their recruitment goals. So they had to pack up, and then they had to change to a more less rural, and they think it was more, they couldn't exactly pinpoint what the issue in the rural area was, other than they didn't find that the community was as interested when they went into the city. That can probably be dived into more deeply, but that was the kind of the issue they faced there. That was in Illinois. Technology, that varied amongst sites. Some found having, we did e-consent on tablets. Some found it as an advantage, and then some it had problems. A lot of the testing occurred outside, so there was a big issue with Wi-Fi depending on where they were located. And although most people think, working with technology is easier, but then that's usually for the staff. For the actual participant and having them work with these tablets and or iPads, it was too much. So there was hesitancy among that with the actual participants. Staffing, again, everything came together rather quickly. And then the staff themselves are experiencing COVID-19. So they were getting sick, a lot of understaffing, not being able to support the influx of participants that actually needed testing. There wasn't a good matchup with the staff, so that delayed recruitment in some of our locations. Again, there were also some literacy barriers, working with interpreters, that felt issue. We did have to have interpreters on the line for some participants, but I know one of the sites reported that even with that, some translations, some of the participants even had different dialects in the same language. So that was an issue as well. So there were a number of challenges. And as you know, the study is still ongoing. We're going till 2026. So we're still currently dealing with some things while we're not recruiting. We're in the follow-up phase with the participants. So a main concern right now is patient engagement, keeping our participants involved in this study, holding on to those patients. And with that, I guess also part of the lesson learned, ideally we would have thought of a patient engagement strategy, earlier on, but we're here now. So we established a community advisory board, and they're here to help us, be that bridge between us and the participants, keeping them involved, reminding them of their surveys, helping us understand how to communicate with their populations. That'll differ from city to city. That's very nuanced. So we're utilizing them to provide some feedback for us and how to better engage and have the participants stay engaged and remain with us. So that's just a little bit of the processes. I think earlier on, we could have just working with lab and different things, just kind of maybe automating some processes. Hindsight is 2020, but it worked out the way it was supposed to work out. It's still ongoing. We're still moving through with it.
Thank you for that, Christina. And it was very important of you to highlight the Community Advisory Board. As we know, patient engagement and participant engagement is key for cohort studies such as MRCIS, but especially when it's in these hard to reach populations. So just a little bit about some of the key findings that we had at baseline in the cohort. We did find a prevalence of positive SARS-CoV-2 overall of approximately 26%, but when looking at the sites between Tesh, which is in Louisiana, Primary 1, which is in Ohio, and Osceola, which is in Florida, we saw a wider gap between positive and negative SARS-CoV-2 infections, whereas at JWCH, which is in California, and Aunt Martha, which is Olympia Heights, the discrepancies were a little bit smaller. When looking at access to resources, we saw that majority of the population did have access to internet and reliable transportation and also reliable utilities. But this was something that we wanted to look at specifically because at that site in California, quite a large proportion of the participants enrolled were of the unhoused population recruited from Skid Row. So we just wanted to see how the access to resources played out across the sample. We did find that those who were aged younger than 65 years old had approximately 2 times increased odds of SARS-CoV-2 infections, as well as anyone that identified being in a minority group, so Hispanic or Latino or non-Hispanic Black participants had a twice increased likelihood of SARS-CoV-2 infection. We did find that access to stable housing and access to those resources did reduce the likelihood of SARS-CoV-2 infection, as well as residing in a rural area also reduced the likelihood of SARS-CoV-2 infection. Prior history of COVID symptoms, as well as being in a larger household or in a household where someone had a prior COVID infection, also increased the likelihood of all participants having a positive SARS-CoV-2 result. This was some of the data that we collected, so I just wanted to ask Ms. Shantoy Hansel, can you comment on what data is currently being collected in the cohort?
So currently, we have our biannual self-reported data, which we collect every 6 months as self-reported. On vaccination status, we have data on health habits, comorbidities, mental health status, specifically in relation to COVID-19. We have ongoing collection of self-reported COVID-19 symptoms. We're monitoring persistent symptoms post-recovery from COVID-19. So in the future, we could look at long-haul COVID. We have self-reported vaccine status, and we see that some of our participants have over 6 to 7 COVID vaccine. We have current data on vaccine hesitancy, as well as baseline data on vaccine hesitancy. We're in the process of collecting EHR data from each of our participants. So at baseline, they signed an agreement that we're able to access their EHR. So hopefully in the future, we'll be able to connect their self-reported data with their electronic health records. We also have, as Dr. Coudray said, We have our biobank, which presently stores our serum and whole blood specimen samples. And our plans, we have plans underway to expand the biobank to include additional types of samples from our participants. We have also been recording the cause of death for some of our participants. And hopefully in the future, we're hoping that we're able to corroborate these records with the NDI for verification of cause of death.
Thank you. And as I mentioned before, MRCIS began recruitment before vaccines became available. And even though vaccines are available currently, there is some medical mistrust around how vaccines for COVID specifically were developed, and there's somewhat of a bit vaccine hesitancy that is still prevalent. So Dr. Maya, can you comment on if we were able to explore vaccine hesitancy or uptake within the MRCIS cohort, and any thoughts you have around that area?
Well, yes, we have very good thoughts. We actually published a paper in JMR Public Health and Surveillance on vaccine hesitancy at the baseline and what factors seem to be associated with vaccine hesitancy. I think we'll probably put it somewhere in the chat or et cetera, the actual publication link if you're interested in reading it. I'm going to just give you a little bit of the highlights. The first thing there was no universal magic bullet across all these diverse centers in terms of a primary reason for vaccine hesitancy. The proportion of participants in different areas, California was lowest, around 30%. These are round numbers, and highest in our Florida site, about twice that amount. And the other sites were in between. So there wasn't a universal factor that we could say, aha, we found it, that was correlated with vaccine hesitancy across the population. In some of the areas, it seemed to be more prominent in minority populations than non-minority populations. And the conclusion from all that is that there were individual contextual factors that influenced the population in each site in terms of their degree of vaccine hesitancy. There's a lot more details in the paper, obviously, than I give you in just a moment, but maybe some of our colleagues that were co-authors could add additional commentary.
I would just like to add some additional commentary on that, because I remember one of the key findings being that actually women had higher vaccine hesitancy than men in the population, which is something that we thought was surprising, because usually women were more likely to push men in their lives to seek certain healthcare. So that was something that was interesting. Also on the screen, we do have a QR code that you can scan that will take you directly to this published manuscript, as well as the link was just placed in the chat. So I will just leave this up for about 3 more seconds for anyone who's interested in reading the entire article. Okay. This is a question I'd like to throw out to the entire panel, or anyone who has thoughts. Given what we know and what we've done so far with the MRCIS cohort, what tool or prevention strategy would you suggest as the most effective method to reduce the risk of SARS-CoV-2 infection?
Well, I can jump on that. Well, it's actually a combination of things. Safe distancing, wearing protective masks, vaccines, getting vaccinated. And again, I can, as a clinician, I can tell you, I still recall in 2020, 2021, the story will often go that a patient calls my office, oh, I tested positive, I'm coughing. Then next I hear I'm in the hospital, I'm in the ER. Then next I'm in the ICU, then I'm told the patient had died. So that was the scenario that we saw back then. But nowadays, when I get those calls, patients just call, oh, I'm coughing, I tested positive, and 2 days later, I'm fine. Again, that's just a reflection of the fact that a lot of people are vaccinated. There are other things that actually like keeping your immune systems in the right position by reducing undue stress, getting adequate rest, consuming food that is more plant-based and a lot of leafy vegetables and all of that. So those things do help to boost your immune system. So I would say at this point that at least for me, I strongly believe that vaccines do make a lot of difference, and I encourage all of my patients to get fully vaccinated.
Thank you.
And I would like to add too, staying informed and keeping up to date with the latest information around COVID-19. We know that people aren't dying as, during the pandemic because of the vaccination, but we still need to keep up to date on the latest information and making sure that we're all still informed on the emerging variants and changing public health advice.
I'll just say this in a somewhat more humorous fashion. My background is a clinical virologist, and I've never met a vaccine that I didn't love, both for SARS-CoV-2, influenza, if you're very old, RSV, pneumococcal vaccine, etc. I mean, these are the miracles of modern medicine. And unfortunately, there's a lot of biopolitics that are tied around vaccination requirements, etc. But on an individual basis, the single greatest thing we can do is to maintain our vaccine status for SARS-CoV-2.
I would just add, one of the things we saw in the study and that we all experienced as we went through the pandemic was the access to vaccines was so critical, and that vulnerable communities sometimes, in terms going back to that infrastructure, are some of the last to get access. And so I think it's just a reminder, the more we can do to make sure that we build proper public health infrastructure, and including research infrastructure in vulnerable communities, the better we'll be able to respond and prevent future infections.
Thank you. We did receive one question in the Q&A that I'd just like to read and ask the person who posed the question for clarity. The question states, were you able to collect data pertaining to MRCIS incidents? If I'm getting that correctly, you can correct me if I'm wrong. Uncertain what you mean by MRCIS incidents, but in terms of the data collected in the longitudinal study, we are collecting any self-reported comorbidities, any instances of COVID-19 related hospitalizations, or if they sought care related to any COVID-19 symptoms that they may have experienced. And Ms. Hansel-Kidney could expand further.
So I could, that's the vaccine adverse event reports. So we don't have, not self-reported. I just started going over their EHR records. I haven't seen any. So short answer, no.
Thank you. And Dr. O, if you comment on, do you have any thoughts on what factors should be considered when trying to characterize a long-haul COVID? You know, right now there's no standard ICD-10 classification for long-haul COVID, but if powers that be gave you the power to develop an ICD-10 code, what do you think we should consider?
Well, let me start by defining long-haul COVID. Well, long COVID is generally defined as continuation or development of new symptoms 3 months after the initial infection, with the symptoms lasting for at least 2 months without an alternate explanation. Now, the main thing to keep in mind when characterizing long COVID is the fact that it is usually a multi-systemic disease. Initially, there was this misconception that long COVID was a respiratory illness with protracted cough and shortness of breath. Yes, that does happen in some patients, but it is actually multi-systemic. It affects multiple systems, including neurological manifestations like myalgic encephalopathy / chronic fatigue syndrome, which is often described by patients as brain fog and chronic fatigue, particularly with mild exhaustion. Cardiac manifestations include things like postural tachycardia syndrome, also known as POTS or POTS. This is a situation where patients develop rapid heart rates just from rising from sitting to standing or from lying to sitting, and they get lightheaded, they get flushed. There are also vascular and clotting abnormalities, which make some patients develop strokes, deep venous thrombosis, pulmonary embolisms. Other manifestations include diabetes, autoimmune syndromes, kidney injury, erectile dysfunctions. So this is a whole array of manifestations. And I guess one of the challenges with long haul COVID is that some of these manifestations are not easily detectable by the common clinical tools that we deploy, like HCT, MRI, or nerve conduction test. We need finer tools to be able to actually define them and identify all the different systems that are involved.
Thank you. And just to throw out to the rest of the panel, given what you commented on, Dr. Ola, what types of areas for future research should we be focusing on primarily for long haul COVID?
Well, I would say that we do need trials to further elucidate the hypothesized underlying biologic mechanisms of long COVID. It is widely believed that long COVID might be due to 4, potential mechanisms. One is autoimmunity, where essentially the body turns against itself. Neuroinflammation, that is inflammation of the nervous system. Viral persistence, where patients have persistent high elevations of not only even COVID virus load. It is believed that in some situations, some of the viruses get reactivated, like Epstein-Barr virus, herpes virus, that they get reactivated. And also there is coagulopathy, where there is the whole clotting system goes into disarray. Now, we need trials to clearly elucidate these mechanisms. But more specifically, we need trials to test whether or not drugs that mitigate this so-called, these believed mechanisms actually make an impact on long COVID. For example, let's take autoimmunity. Using drugs like steroids or some anti-cancer drugs that we use in patients who have autoimmune diseases, will that help COVID? Or using antiviral drugs that will reduce the total load of viruses in the body, would that help COVID? How about coagulopathy? Treating patients with anticoagulants, would that help COVID? So we need to elucidate these mechanisms clearly, and we need to figure out whether or not drugs that target these mechanisms will translate to improvement in long COVID.
And Dr. Landry, if you could
I would just ask.
I was going to ask you, thank you.
Makella, you asked your question.
I think you're going to answer it, but I was just wondering, from your expertise in genomics, what role did you think that genomics would play in both the assessment of long haul COVID and potential future treatment?
Yeah, I think it's a really promising area. As a geneticist and someone who works in the space of precision medicine and precision public health, I'm really interested in how we can sort of bring understanding to all of the other researchers that's going in this area to try to identify markers for long haul COVID, which those markers can then be used for targeted therapies, as Dr. Akinboboye was talking about in terms of clinical trials. One of the biggest deficiencies we've seen in the research in COVID is the lack of minority and vulnerable populations. And so we have a very rich opportunity with our cohort to sort of bring that perspective, that information, that evidence base, so that we can have a more equitable distribution of whatever the targeted therapies that may arise, whatever the understanding of the clinical effectiveness of those therapies, the diagnostic tests. And this is a really big issue in this space. The lack of minority and underserved populations in research limits our ability to translate that research that is happening in the therapeutic space to those populations. And so I think that there's a real opportunity to understand the targets, understand the genomic or molecular contributions to long haul COVID in this population, but also sort of expand upon that in terms of the relationship between the participants in our study and how they may respond to treatments, as Dr. Akinbaboye pointed out.
Thank you. I think something that has been highlighted throughout the entire webinar is the uniqueness of the MRCIS cohort, given that we are recruiting from medically underserved populations. We have a high proportion of participants who identify as minorities, and for the need for further research in this area, as well as the additional sample collection and the biobank that we've established. So I was just wondering, Ms. Hansel, if someone was interested in working with the MRCIS cohort, how would they go about that process?
So if anyone is interested, I just put the email in the chat. You could email us at the COVID study admin at nmqf.org and we will respond.
Thank you. And just to give,
I think Dr. Ola is trying to say something.
oh yeah, sorry, Dr. Ola, go ahead.
I also comment about, in addition to working with the MRCIS cohort, again, as Dr. Maya has pointed out earlier on, the beauty of what we're doing is bringing research to the community. And the challenges and how we overcame the challenges working with these FQACs is really, I think, a good body of knowledge that we also at some point we're going to share. I think really detailed how others can explore this avenue to bring research to the community.
Thank you. So we did describe a lot of the work that we've already done, just characterizing the cohort and some of the key findings that we found on at baseline. However, data collection is ongoing, and we do have a few key areas that we'd like to focus on or are focusing on currently. First of which we explored a little bit is long COVID syndrome and looking at how we will characterize that and possibly developing a tool. We're also interested in the relationship between diabetes and SARS-CoV-2 infection. We do have some baseline data on glucose levels and hemoglobin A1C. We have also explored nucleocapsid and spike protein-based COVID assays. That work is pending publication as it was just accepted, so we can follow up with the participants with a link to that once it's available. We are interested in looking at SARS-CoV-2 vaccine uptake. One of the ways we assess that is with our biannual surveys. We do assess if any additional vaccines were taken, boosters, and we do also capture date of vaccination as well as the type of vaccine that was administered. This is currently self-reported, but we will be verifying once we have finished extracted the electronic health records. We have also recently began exploring mental health and SARS-CoV-2 infection. We've done this specifically with looking at grief among those who may have lost a family member or any type of close person or friend to SARS-CoV-2 infection, grief around having SARS-CoV-2 themselves. We've also looked at the anxiety or depression associated with the pandemic, or if any effects were felt by that participant in terms of loss of work or loss of activity surrounding SARS-CoV-2 infection and how this affected their mental state. We're also looking at vitamin D levels in SARS-CoV-2 infection and how this may have reduced risk, and if there's any discrepancies between racial and ethnic disparities. We have established our initial biobank with samples collected at baseline, and we are working on expanding this biobank with additional samples as well as conducting additional testing. Just for reference, this is our study email for anyone who is interested in collaborating on existing or future projects with the MRCIS cohort. And in this point in time, we would like to invite questions from the audience.
I also want to quickly point out that Cancer Kidney just posted the baseline manuscript of first authored by a moderator. I think that's something that people can take a look at and get a sense for the whole entire study.
Thank you for mentioning that, Dr. Akimboye. That's it's our primary paper describing the cohort as well as some of the key findings that we found at baseline. It explores some of the social determinants of health. It also touches a little bit about the different sites that we recruited from and the populations that they serve. Dr. Landry?
Yeah, I would just like to say that one of the key things that we haven't mentioned, and I think it's our role as researchers and sort of public health advocates, where we're thinking about this from this standpoint, but to the extent that anyone in the audience is a funder, I definitely want to urge the encourage more funding in the space of building research infrastructure in diverse communities and underserved communities. I think one of the things that we saw and that we talked about were the challenges, but those challenges could be addressed with more investment in building that infrastructure. And, maybe that's can be sourced from a variety of different places, but research funding and funding for clinical infrastructure, I think is imperative to expand work and move it forward just even beyond our own setting.
Thank you. I'm just checking the Q&A. I see no questions at this time, so what I would like to do is invite the panelists. If you have any final thoughts or comments or anything you would like to mention about the MRCIS study, if you enjoyed working with me on the MRCIS study, you can talk about that too. But anything you'd like to highlight before we close off the rest of the webinar.
I'd just like to add that I'm sure there were some among us and even in the community that would have thought this couldn't be done. And in fact, it has been done. Participants were motivated to volunteer their time and some of their clinical specimens in a way that was compliant with all the legal challenges that go into that. Community centers that had never been directly involved in research projects became research project administrators. So this is kind of like putting a stake in the ground saying this can be done, and it is being done. And we hope that it'll inspire more projects, maybe even outside of SARS-CoV-2, to be done in the communities that need it the most. Thank you.
And just to piggyback off of Dr. Maya's comment, I think one of the key things that's done in MRCIS that aren't commonly done with a lot of clinical trials, especially in this population, was the establishment of a community advisory board. And that was an extensive process of trying to identify key stakeholders at each of the clinical sites and recruiting members from the community. The community advisory board is diverse, made up of members of local government, radio hosts, and just actual advocates of the community we were interested in recruiting. And they do play a very active role. They review the survey instruments before it's sent out biannually. They give feedback, and we implement their feedback. We don't just ask them for it, we implement their feedback. An example of that is the survey is biannual currently, but originally it was every quarter. And that was feedback that we received from the CAB that might have been something that was too frequent. So the community engaged approach that we have implemented speaks to our investment in the community as well as the success of the project.
I just wanted to add that when we started working on this, we were in the full throes of the pandemic. And, one of the things I remember thinking about amidst sort of homeschooling young children at home and doing different things is I wanted to use my skill set to impact communities that were underserved. And so I think that one of the things that I am grateful for is that NMQF did provide that opportunity to be a part of this study, to be able to sort of use the tools and the skill sets and things that I have invested in to apply to doing research in minority and rural communities. And I think that
Oh, I think that we lost Dr. Landry. But if I had to guess what she was going to say, is that she feels great sense of fulfillment working with this population and being able to apply the many years of experience in genomics and epidemiology. I hope I have not misspoken on her behalf.
Makella, you captured it perfectly.
Thank you.
I also want to add that this study is also one of a kind. We haven't found anything research-wise that have the population that we do, the sites that we do, and the data that we're collecting. So it is one of a kind study.
I see no additional questions in the Q&A. If it's okay with you, Brandon, as I don't see anything additional, and I think we've gathered all the comments from the panelists. At this time, we'd like to thank you for your kind attention. We hope that you would be willing to work with us on this project. Feel free to reach out. Ooh, I spoke too soon. Q&A. Oh, there's a mention of a similar study in Flint, and thank you. If you can just email us and we can look into ways for future collaboration. If you'd like to expand on some of that work, we'll be happy to discuss further. At this time, if there's no further comments, we'd like to thank you for your participation. And please feel free to look at all those links of the published manuscripts, and I can work with Ashley and Brandon to have that sent to you after the webinar as well for your personal reference. Thank you, everyone, and thank you to our amazing panelists.